The Washington Manual of Surgery podcast is based on the 9th edition of the best-selling Washington Manual of Surgery.
This podcast is meant to condense key topics from our manual into bite-sized episodes for your convenience. Now, on to this installment of the Washington Manual of Surgery podcast.
Hello, everyone, and welcome to the Washington Manual of Surgery podcast. We bring you everything you need to know about high-yield general surgery topics built for your just-in-time learning. My name is Jorge Zárate, and I am one of the chief residents in general surgery at WashU. And on this episode, we're thrilled to have Dr. Stephen Hunt here to review the management of all things colon and rectum.
Thanks for having me.
Thank you for being here. So Dr. Hunt is a professor of surgery at Washington University in St. Louis in the section of colon and rectal surgery. He did both his residency and fellowship here at WashU, and you will recognize his name from several NCCN clinical practice guidelines. And on a more personal note, Dr. Hunt is also one of my mentors, and his mentorship certainly influenced my decision to pursue colorectal surgery myself. So thank you, Dr. Hunt. So the WashU Manual chapter on colon and rectum covers a wide variety of topics, so we'll be focusing on benign disease for this episode, and we will be recording a separate episode later discussing cancer of both colon and rectum. But without further ado, let's dive right into it with a case scenario. So you get a call from the emergency room with a pretty common consult. We're going to talk about diverticulitis. They have a 56-year-old woman with left lower quadrant pain and low-grade fever for 2 days or so. CT scan shows wall thickening in the sigmoid and pericardial fat stranding, and the ED is asking if they can admit to your service. How do you think about diverticulitis, and what's going to change how you manage this patient in the acute setting?
So diverticulitis is a complicated subject because these patients are so very heterogeneous. I mean, you've got patients like this who come into the ER with fairly benign symptoms and a fairly benign disease, and then you have patients where it can be life-threatening. Most of the time, when we get called to see these patients, they have more serious disease. I mean, the more minor disease, the stuff that the literature says you can manage without antibiotics, just by diet alone. We generally don't see those types of patients, so I don't want to talk too much on that because I don't do a lot of management of the patients who have very, very early stage benign disease. Our management is more patients who have worse disease and need to either be hospitalized or need surgery. So as far as our management up front, it's all individualized, and there's a lot of data to suggest that probably the way that I manage it is a little too conservative still. As I said, for most of the patients who make it, to my office or to our ward in the hospital, those patients are going to get IV antibiotics, at least to start, and those patients will probably be NPO until they are basically pain-free and not tender on exam. And that's kind of my goal, and that's what I tell the residents is it's all based on their exam and based on their complaints. So, our patients generally might have a phlegmon or even close to an abscess or even a small abscess that's not amenable to drainage. And those patients, in my practice, generally get the IV antibiotics and NPO for a while. Now, there's, we'll start clear liquids fairly early if they have a relatively benign case. And I generally keep patients on clear liquids for a week if they have an attack that's serious enough to admit them to the hospital. Mm-hmm. And then generally we'll put them on a low residue diet for a month. And then after a month, we actually flip things around and put them on a high fiber diet with fiber supplementation also. Mm-hmm.
And so something that's going to come up for the residents who are going to be studying for the ABSITE is, the Hinchey classification and how that changes your management as the consul's resident. And so it sounds like you're describing sort of, what would be sort of Hinchey 2, somebody who has a small abscess but is, too small to be drained. Maybe like that's 2A, I think, in the new classifications. But who are the people that you'd be thinking about taking to the operating room? So
in general, I mean, and if you look back at the Hinchey stages is a very old staging mechanism. And now we go more by CT staging, and Hinchey has kind of migrated in that way. I think we've done little subtle changes to the way that we talk about the Hinchey classification. But Hinchey stage 1 and stage 2, stage 1 is generally almost always managed with antibiotics, sometimes oral, sometimes IV, depending on how sick they are. If they have a true abscess, a pericolic abscess would still be a Hinchey stage 1 because because it's not in the pelvis. So a pericolic abscess that is amenable to drainage, we'd like to get them drained as soon as possible. Up to 3 to 4 centimeters. Most abscesses that are up to that size can be treated with antibiotics alone. But if it's an easy chip shot to drain a 3 centimeter abscess, oftentimes we'll ask the interventional radiologist to do that. Patients who have an abscess that's not drainable, a 4 centimeter abscess that's just surrounded by bowel and deep, more central in the abdomen, those patients we start on antibiotics, and usually we give them 48 to 72 hours of antibiotics, and then we'll re-image them. And I always tell the patients that generally one of two things is going to happen. It's either going to respond or it's going to become drainable. Mm-hmm. And if we re-image them at 72 hours and they're still symptomatic and don't have a drainable abscess, then they haven't improved. If they haven't improved at 72 hours and we can't act on our imaging, then oftentimes those patients will need surgery in the more, not urgent, but on that hospitalization. Patients that become drainable get drained, at 48 to 72 hours, and patients who improve, in general, we kind of transition them to outpatient management
with oral antibiotics.
Yes.
Okay. All right. And then the people that would go to the OR emergently would be the people that from the get-go are having peritonitis and concern for,
Yes.
more like an uncontrolled.
So probably about 10 or 15 years ago, Dr. Much, my partner, published what I thought was a really important paper on the non-operative management of diverticulitis. And one of the things that he showed in that paper was that even free air in a patient, even an abscess, all these things that we used to rush to the operating room can be managed non-operatively with some caveats. Patients that have distant free air, not just localized free air around the colon, but even free air over the liver, can be managed non-operatively if they do not have generalized peritonitis and if they are hemodynamically stable and if they will tolerate that. I mean, you don't want a patient who's on a boatload of steroids with free air, and you don't want to necessarily watch that patient. But relatively healthy patients who should tolerate, a little illness, those patients we generally will manage with NPO and antibiotics. If they get better, we obviously convert them over to oral antibiotics. But if they do not improve or if they get worse, and we follow them fairly closely with serial exams, if they develop generalized peritonitis, if they have any change in their vital signs and they become at all hemodynamically stable, and I'm not talking about needing pressures, I'm just talking about becoming tachycardic, those patients usually will take to the operating room.
Okay. So, let's say that this patient got antibiotics, they got better, they got discharged, they, advanced their diet as we discussed, and then they come see you back in clinic a couple of months later, and they said that their PCP told them that they need to have their colon out. What discussion do you have with them?
So again, when I started practice, somebody who had quote, complicated diverticulitis, and that includes any abscess, drained or undrained, that patient back in the day we would, once they got over their acute episode, we would sign them up for surgery. Patients under 40, we would sign them up for surgery, and back then in 2 attacks of even uncomplicated diverticulitis, we would tell those patients they need surgery. That has evolved quite a bit now. Now we can take patients who have had complicated disease that's been managed either with antibiotics alone or with drainage. Even those patients are not necessarily, defined candidates for surgery. And most of the time, if they are asymptomatic and they come back into our office having healed from this complicated attack, we'll watch them. And that's a discussion that you have to have with your patients. This is all, patient-directed surgery now. Somebody that comes in and said, I had complicated disease. I spent, half my life in sub-Saharan Africa, and there is no health care there. That's a patient who we might talk about operating on, because of those reasons. Patients who have right now, kind of the cutoff we say is about 4 attacks, but that obviously can move in one direction or the other because of patient wishes. Like I said, the person who's out of the country a lot or doesn't have access to health care sometimes, we will have a lower threshold to operate on that patient. Other patients may tell me they've had 20 attacks and they're used to them and they know when they're coming and they call their primary care doctor and get antibiotics. If that patient doesn't want a sigmoid colectomy, I'm not going to push them to get one, because the one thing that we know is that the truly complicated diverticulitis, the diverticulitis that either leads you to go to emergency surgery, can be life-threatening, can lead to you needing an emergent colostomy. That generally tends to happen on the first, second, third attack. And as you build up all of the, if you've had 5, 8, 10 attacks, your likelihood of having that, while not zero, is very, very low. And I communicate that to the patients, and then we make the decision together.
Mm-hmm. And if you do decide to go to the operating room, something that comes up often on the website is that you have to get a colonoscopy first, to rule out malignancy. Is that
exactly? And there's data to suggest that not every patient who has had diverticulitis needs a colonoscopy. Mm-hmm. Okay, and while I know that data is good, I think most patients who are in their 30s, 40s, and certainly in their 50s, if they have not had a colonoscopy and they have an attack of diverticulitis, I'm going to recommend that they get a colonoscopy, because a small percentage, somewhere 2 to 5%, depending on what literature you look at, of those patients will have a cancer. Mm-hmm. And they're more likely to have a cancer if they have a stricture. They're more likely to have a cancer if they have a pericolic or a pelvic abscess. Those patients are also more likely to have cancer. But I don't think it's worth missing a cancer, even if it is 1 in 50 or whatever chance. I don't think it's worth that. So anybody that's had diverticulitis and has not had a colonoscopy in the last 5 or so years, I will recommend a colonoscopy. Now, if it's a patient with disease that we're going to operate on and they had a colonoscopy a year and 18 months ago, kind of in the midst of all of their attacks, I'm okay with that. And I've kind of arbitrarily set a 2-year, span where I'll say if you've had a colonoscopy in the last 2 years and that's been kind of during your attacks of diverticulitis, I'm not going to have them get another colonoscopy. Mm-hmm. But if it's been 4 years and they haven't had a colonoscopy, I want to get another colonoscopy, because you don't want to go and take out their sigmoid colon and then leave a 3-centimeter polyp right proximal to your anastomosis, right, or something like mm-hmm. that.
Okay, and if we were talking about the patients that did have surgery in their index admission and now are coming back saying, hey, I really want to get rid of this bag, do you, we talked about the colonoscopy a little bit, but do you do contrast enemas for these patients routinely?
And so I probably practice a little bit of overkill, because I've just been burned in so many different ways, right, by taking these patients back. Mm-hmm. That colostomy takedown on the surface should be a really easy operation, but in reality, it can be really, really difficult. So a patient that is going to have a colostomy takedown, generally, I want to get a CAT scan when when they were sick in the hospital. I want to get a CAT scan when things have settled down to assess their anatomy. I also will generally get a hypake enema to make sure that rectal stump is not leaking and that it's not strictured anywhere. And if they, as I said, if they haven't had an endoscopy in 2 years, I'm going to get an endoscopy, and that includes scoping the Hartmann's and the colon.
Mm-hmm.
Yes, sir.
Okay. And what is the role for stents in these patients?
So I look at their scans, and if any of their inflammation has been anywhere around the ureter, left-sided almost exclusively, but if there's any inflammation close to the ureters, I will ask to have preoperative stents. Mm-hmm. Patients with colovaginal and colovesical fistulas, those patients may, you're going to, when you are in the pelvis, deeper in the pelvis, not where we normally encounter the ureter around the iliacs, but deep in the pelvis laterally, those ureters are much, much harder to find. And I think our sense of where the ureters sit in the pelvis can get distorted, especially in patients who've had diverticulitis. So those patients who have colovesical fistulas or a big pelvic phlegmon or any of those things, I'll also put stents in those patients.
Mm-hmm. Great. Okay. Switching gears to a different topic, inflammatory bowel disease, which I think can seem like a very daunting topic just because, it's a complicated disease and a lot of it is medical. So I think a surgery residents maybe get a little bit coy around that topic. But, broad strokes, thinking about ulcerative colitis versus Crohn's disease.
So when that's important, I mean, obviously it's important to make those diagnoses whenever. But as surgeons, when we need to really differentiate between someone who has Crohn's colitis and someone who has ulcerative colitis is when we're planning on operating on them, because their ultimate course is oftentimes determined by their disease. So, if a patient presents to us, oftentimes the way these patients come to us is they're admitted to the hospital. They've been refractory to medical therapy. They're relatively ill. They have severe refractory colitis, and we get called to see them. And a lot of times we like to be involved early in that hospitalization because we want to kind of plan. We don't want to be called the day they need the surgery when they're in extremis and sick. So we ask our GI and our medicine colleagues to try to consult us early on, and oftentimes these patients have just gotten their first dose of steroids, but they usually have been long-time refractory patients or have had really accelerated disease that's just not getting better. And then we sit and we talk to the GI doctors, and I say, what do you think their odds are of responding to steroids or Remicade or whatever biologic therapy that they're planning? And then we talk out and we say, okay, they're stable enough now that let's give them a few days, and then we'll say, okay, let's reassess things next Wednesday or whatever day it is, and talk again, because that's also a shared decision. Of course, the patients are involved in that too, but I think that's really important for the internists and for the surgeons to talk about things. So a patient presents in-house, bad colitis. Oftentimes they've only had a flex sig because the gastroenterologists do not want to go trying to force their way all the way through the colon. And then we look at the clues. What do the pictures look like on the flexible sigmoidoscopy? Do they have long linear, like bear claw ulcers? Is the anus involved? Have they had any anal disease in the past? That's something that hints at Crohn's disease, any anal disease. The bear claw ulcers hint at Crohn's disease also. Skipping. So anybody that has no proctitis but then sigmoid colitis, unless they've been getting topical therapies, Rawasa enemas or steroid enemas, unless they've been getting topical therapy, that should cause an alarm bell to go off that this may not be UC. Okay. Certainly small bowel disease says that it's Crohn's disease also. And a lot of times when we end up operating on these patients, we do not know what they have. And we count on what the specimen looks like when we open it in the operating room and what the pathologists say. So one of the reasons for doing a 3-stage restorative proctocolectomy, meaning you take out the colon, leave the rectum, give them an endoleostomy. Second stage is do a proctectomy, make a J pouch, and give them a loop ileostomy. And then the third stage is to take down the loop ileostomy. When we generally get consulted in the hospital, even if we're sure it's UC, if they're sick, they're going to get a 3-stage restorative proctocolectomy. If they're healthy and we're positive it's UC, we might do a 2-stage proctocolectomy. We might go in and take out the colon, the rectum, and make the pouch and give them an ileostomy. And then patients with indeterminate disease, those patients are always their first initial operation is going to be a subtotal or total abdominal colectomy with an endoleostomy, and then we wait for the pathology to come back. Okay? And oftentimes the pathology will come back as indeterminate. And in a patient like that who has never had small bowel disease and who has never had anal disease, we will consider for a pouch. Okay? Patients,
meaning that you are thinking that it's more UC than Crohn's.
Well, I mean, the data for pouches in patients with Crohn's disease, most of the data suggests, and this data was these studies weren't done prospectively. They're like, we're going to do pouches on a bunch of Crohn's patients. These are patients who were ultimately found to have Crohn's disease or who, got a pouch and even with known Crohn's disease, but these weren't prospectively studied, and they certainly weren't randomized. But the data suggests that in a patient who has Crohn's colitis, not small bowel Crohn's and not anorectal Crohn's or anal Crohn's, that they have about a 50% chance of living, going to their grave with their pouch. So they have a 50% chance of losing their pouch. You just have to talk to the patients. If it's a more elderly patient, generally I would push them more towards avoiding the pouch. But a young person, they have to know the risks. They have to know that they could lose their pouch. And sometimes losing a pouch is not a simple thing. Those patients can get pretty sick when you end up getting to the point where you're taking out the pouch. But if you have an informed discussion with these patients, I think it's safe to do a restorative proctocolectomy on a patient with Crohn's, as long as they meet those other qualifiers.
Okay, backtracking a little bit. So we talked about how you have to see how these patients do while they're being managed inpatient before you're trying to give them a chance to avoid surgery in that admission. So what are you looking for to decide, this has failed, we need to go to the OR for that subtotal?
There are a number of bowel movements, there are vital signs. Patients that have severe colitis who are having 10 plus bowel movements a day, blood in their bowel movements, fevers, elevated white count, tachycardia, all of those things should push you in the direction of surgery, certainly. But a patient who's just been medically refractory, if they're not sick, I'm willing to give the GI doctors as much time as they would like, to go through the medications. One of the things that you notice after you do this for a while is that the patients that don't respond to steroids are very unlikely to respond to biologics. So, a lot of times we'll see a patient who's been on steroids for a week and their gastroenterologist says, well, I'd like to try Remicade. We're going to start it this week. And you say, okay, I'm happy to do that as long as they're not sick, as long as they're, still comfortable.
Stable, yeah.
Do that. But know that patient is very likely going to end up with surgery on that hospitalization if they haven't responded to steroids.
Mm-hmm. And then kind of a basic question, but for the people listening at home studying for the EBSITE, why do we do a subtotal versus a total proctocolectomy?
So multiple reasons. Number one, in these patients, most of them, as I said, are in-house, and they've either been on a lot of poisons, steroids, some of these bigger biologics, and other immunosuppressant drugs. That's one reason, is because you don't want to make a pouch in somebody who has been on a lot of steroids, somebody who is immunosuppressed, malnourished, or sick. Mm-hmm. Any of those reasons, that patient should have a 3-stage restorative proctocolectomy. A lot of times when we do the first stage of a 3-stage pouch, those patients are sick, and they always have bumps in the road during their hospitalization. Very few of them that we do urgently or emergently, very few of them just waltz right out of the hospital because they are so weakened by this disease that's been beating up their immune system and beating up all of their normal physiologic systems for so long. Those patients really have a tough time recovering from the first stage. So that's the first reason. They're sick, they're hemodynamically unstable, et cetera. They're on lots of poisons. And then the other reason, as I said, is if you don't know if it's Crohn's or ulcerative colitis, and you want to include the pathology in your decision making.
Mm-hmm. Perfect. Okay. So to round out the discussion with IBD, here's another scenario. We have a gentleman who is in his late 40s, early 50s, who was diagnosed with IBD in his early 20s, and as instructed, he's been getting his surveillance colonoscopies, and his most recent colonoscopy came back with a random biopsy that resulted as high-grade dysplasia. So what are the next steps for this gentleman?
So in general, and my numbers are probably a little old-fashioned, but we used to say that somebody with high-grade dysplasia probably has a 40% chance of having a cancer in their colon. Okay, it's certainly a marker for them being in high risk for developing cancer. So a patient has biopsies with high-grade dysplasia, and all of the rest of their biopsies are completely benign. Again, that's a discussion I might have with the gastroenterologist. I think but generally, somebody with high-grade dysplasia, you need to talk to them about having a colectomy, okay, and a restorative proctocolectomy if at all possible. The patient, the harder thing is the lower grade dysplasia, and a lot of the polyps that we take out, benign polyps that anybody with IBD or without IBD could still have a benign polyp. And I think a lot of times that dysplasia gets overcalled in those polyps that are just benign adenomatous polyps. I think it oftentimes gets overcalled in them. But patients that have had either low-grade dysplasia in multiple places in their colon on these random biopsies, or low-grade dysplasia on serial colonoscopies, serial biopsies, I think that patient deserves to hear about the option of a colectomy.
And that being because there's a risk of sample error. So if they have so much low-grade dysplasia, the odds of having high-grade dysplasia somewhere is higher, right? So
these cancers that come about in ulcerative colitis they do not develop like the adenomatous,
right.
Adenoma carcinoma sequence. They tend to develop very subtly, and they can come up in a year. And a lot of times they're missed, and it's not necessarily sampling error, but anytime you see this dysplasia, there could just be a focus of cancer that's kind of bubbling underneath the surface, and a lot of these patients, their colons are not normal. So, what would look completely abnormal in your colon, in somebody with ulcerative colitis, their whole colon may be abnormal. So we have to use the clues that we have, and dysplasia is one of the clues that we have.
Okay, perfect. So switching gears to another topic that often comes up on the consult residents list, vascular surgery is calling you because they have a 65-year-old male who's post-op day 1 from an endovascular repair for an abdominal aneurysm. He was doing just fine after surgery. He, was stable from a hemodynamic point of view, but he's having abdominal pain and some bloody diarrhea. So they're asking what it is that we want to do for this patient.
So those patients will always have a CAT scan before we get there, but we will probably want to get a CT angiogram, and then almost without exclusion, before we're going to operate on these patients, we are going to ask GI to come in and do a flexible sigmoidoscopy, or we will do it ourselves. And that's going to be what really determines if you're going to operate on this patient. If you go in and you just see a little mucosal edema and hyperemia, but it's still alive, you can sit tight on that. You want to make sure that you've looked at as far up in the left colon as you can. But patients who have gray, white, or black mucosa, those patients need surgery, and that surgery is going to be an emergent sigmoid colectomy or left colectomy with the colostomy. So, but I think CT imaging and endoscopy in those patients, not next day, that night. They need to get it as soon as possible. And if the GI doctors won't do it, generally we'll do it ourselves.
And so if it's one of these kind of questionable situations, then you would manage with MPO, IV antibiotics.
Yes, sir.
And how long would you watch before? What would you do?
I'd watch their symptoms, and the majority of them, when they stabilize out from all of their hemodynamic instability around the time of the operation, a lot of them get better. They get their volume status goes back to normal, and things resolve on their own. The ones that don't get better are going to get either another CT scan or another flexible sigmoidoscopy, usually within 24 hours. If their first one, especially if their first one was somewhat borderline or questionable.
And something that sometimes comes up for these patients that we manage non-op, they kind of always ask, what's next? Do I need to worry about this? What should I be concerned about?
I mean, I get the thing that would be most concerning long term is that they develop a stricture. Yeah. And those oftentimes are going to be symptomatic. They'll tell you they have belly pain, they have left lower quadrant pain. A lot of times they're picked up on imaging subsequently. And if they are, if they have a CT scan that shows quite dilated colon and then a stricture, number one, they need a colonoscopy to make sure that it is not a cancer. And then they need a discussion about surgery. If they are completely asymptomatic and just have a radiographic stricture, but the colonoscope passes through it and it's not bothering them, I'll usually leave it be.
And the biopsies are negative.
And the biopsies are negative, yes. I'll usually leave that be. Patients with symptomatic strictures are going to, we'll usually schedule them electively for just a sigmoid colectomy with the primary anastomosis, and with good assessment of the blood flow. Now, we assess our blood flow usually just by flashing the marginal artery, opening the clamp to the marginal artery and seeing that they have pulsatile blood flow. If that doesn't work, then ICG or Doppler or some other method can be used to assess the blood flow to the proximal pre-anastomotic colon.
Well, thank you so much, Dr. Hunt, for being with us today. We got through a ton of material on colorectal. There's still a lot left over in that chapter. We really, put in as much as possible in that chapter. So for those listening at home, make sure you do check out the chapter. And at the end of the chapter is also some relevant literature that we that was referenced throughout the episode and as well as through the text of the chapter. So thank you for joining us. That was Colon and Rectum for the Washington Manual Surgery podcast.
Thanks for having me.
We are Doctors Paul Wise
and Jeff Blatnick,
senior editors of the Washington Manual of Surgery. We'd like to thank the residents and faculty of the Department of Surgery at Washington University Medicine, and we'd especially like to thank our associate editors for this edition, Drs. Catherine Caldwell, Ina Chen, Bradley Kushner, Martha Bucky McGilvray, and Jorge Zárate Rodriguez.
We hope that you enjoyed this episode of the Washington Manual of Surgery podcast. For more comprehensive information in a brief outline format, check out the print and digital version of the Washington Manual of Surgery, published by Wolters Kluwer Health and Lippincott Williams and Wilkins. Please search online for the Washington Manual of Surgery 9th edition to purchase your copy of the manual.
To learn more about the educational opportunities available in the Department of Surgery, please search General Surgery Residency at Washington University School of Medicine in St. Louis.